Okay, so my name is Maria Akani. I'm a psychiatrist and a psychologist, and I'm the managing consultant for a company called Renaissance that deals in counseling, coaching, psychotherapy, and psychiatry.
Great, Maria. It's wonderful to have you on this interview to talk about postpartum depression today. And I know depression is not a very well understood topic, and even less so for postpartum depression. So I'm very happy that you are here today to shed more light on this. And I know it's something you are passionate about personally. And it's good to have your wealth of experience and expertise and knowledge on this topic. So let's get right into it. What is postpartum depression? Please tell us more about that.
Okay, so postpartum depression, so I'll start with defining what depression is. And depression is a period when a person experiences a very low mood and they have loss of interest, loss of appetite, low energy. They may have feelings of worthlessness or hopelessness and feelings of wanting to die, feelings of wanting to harm someone else, and really having low appetite, low, well, I already spoke about the energy, but sometimes one of the other things that comes along is either too much sleep or less sleep. So that's depression. So when we talk about postpartum, we're really talking about the time after delivery. And typically it's the 6 weeks after delivery. So when we talk about postpartum depression, we're referring to the depression that develops after delivery. In terms of the technical diagnosis, previously we have what we call the ICD-10, which is the UK way of diagnosing. And for them, they consider postpartum depression for as long as it develops, even within 9 months after delivery. And for the Diagnostic Statistical Manual, which is the US one, DSM-5, it's only considered within 4 weeks after delivery. Previously, it was 6 weeks, but now it's considered 4 weeks. And they also include the period of pregnancy. So they no longer call it postpartum, but peripartum, because they say that 50% of those things start while the person is pregnant. And you find that because so they want to include that all together, inclusive. Yes. So basically, that's what postpartum depression is. And I just wanted to mention that depression is one aspect of what happens in the postpartum period, but some people will have what we call psychosis and so on. So in that case, they may have more of the symptoms of hearing voices and seeing visions. Today, we're talking more about the mood symptoms. So we're talking about postpartum depression.
Okay, yeah, thank you for that distinction with psychosis. So depending on where you are, whether you follow the UK diagnostic system or the US, you might have slight differences, but the bottom line is it's depression around the period of childbirth or shortly after childbirth then. But so,
Absolutely.
I mean, it's supposed to be a very happy time in anybody's life. So what are the risk factors for postpartum depression then? Why would somebody be at such a time?
So there are a number of things. First of all, the biological aspect, the whole surge of hormones that comes in that is increased, and then the risk actually increases after delivery because there's a sudden drop also in the hormones of the estrogen and the progesterone levels, and that affects the mood as well. But apart from that, in the postpartum period, there are other things that really predispose a person to gaining, to having postpartum depression, such as the disturbed sleep patterns. You know, even when you're not depressed, even when you don't have a small baby, if you just don't have enough sleep, you're irritable. You're irritable, you have poor concentration, and so on. But then when that lasts for a while, as is the case with people with newborns, it lasts for quite a period of time. That then disrupts the person's mood and so on. And there is the constant dependency that comes with the responsibility of looking after a baby that you don't get a break from, and that can be quite overwhelming. Other risk factors include things like a first pregnancy, especially if it happens when a person is advanced in age, a difficult pregnancy. So this is a pregnancy that could have had complications throughout or even just during delivery. problems with the partner or the spouse. So it's actually higher in single parents than those that are not single parents. Substance abuse also increases the risk of postpartum depression as well, and other social problems that they may experience. So maybe financial problems that come in as well. Those things can also increase the risk of postpartum depression. Having a prolonged delivery process, like I said, also a difficult delivery might also result in that. And then things like maybe the person has difficulty breastfeeding when they just have the baby and settling down with that. They have poor social support. Maybe they're just by themselves. They don't have family. Those things all affect how easily a person can have postpartum depression.
Okay, so there are quite a lot of factors around it. It seems to be generally, though, that in summary, if there's difficulties around the pregnancy or after delivery to do with the woman's social economic situation or the partner relationships and that kind of thing. But I'm wondering, is it more common in a woman who is having a first child or somebody who's had more children? What are the dynamics around that?
So it's more common in women who have first children. I guess it's the transition and the expectation that they have. The chances that it will happen again when a person has a second child is about 25 to 40%. And then when there's also a family history of mental illness, so if there's a family history of depression or anxiety disorders in the family already, or there's a substance abuse problem, or if there's an underlying mental illness in the person themselves, the chances are actually also higher.
Okay. Well, that's a quite interesting statistics that you present to us then. So what does a woman do if she's feeling this way? What help is there out there? What should one do?
Well, one of the first things I think that women need to understand is that these things are common. So it's 2 to 3%, and considering how many births we have, that is quite common. Of course, the postpartum blues is more common, but still the postpartum depression is also common. And it's important to get help, because sometimes some of the impact that comes with that is that the mother may then want to get rid of the baby or harm the baby or harm themselves, and all those are life-threatening situations. So if you don't get an intervention quickly, then the likelihood of something harmful happening is really terrible. However, actually, when you think about it, postpartum depression is one of those conditions which is fairly easy to treat compared to other psychiatric conditions. And so early intervention is key. Early intervention is also key for the mother, because when they experience that, it takes away their confidence about parenting. Even when the phenomenon is gone, they keep feeling like, I don't know if I can trust myself to be a good mother. It affects the bonding with the child as well. It affects how you relate to the other people at play, like, for example, if there's a partner there. So early intervention is key. So what I would advise the mothers to do, first of all, the midwife should have some knowledge of that. So mentioning that on the review is very important. And sometimes you particularly have to ask for a referral referring to mental health, because sometimes midwives may underplay the symptoms. So that may be important. Just get a screening so that we make sure that it's not something that it's either just irritability coming from poor sleep or transition, rather than a psychiatric diagnosis that needs medication. Otherwise, there is help. And I think I really like what you're doing right now, because in our cultures, I'm not sure about places like South Africa, Malawi, but in Zambia, when such a thing happens to a woman, there's always rumors around how, oh, the husband must have been unfaithful, or the woman herself was unfaithful and she looked at the baby when the baby was born. And so there's a lot of misunderstanding. So people end up going for prayers or traditional medicines and so on, therefore prolonging the illness, prolonging all the mystery around it, which causes more harm in the relationship and in the recovery process.
Okay, that's quite interesting that there are some of these conceptions about things. I guess that makes it harder to get help. So, but you seem to be saying so that the first point of contact in terms of getting help is actually in terms of your antenatal or postnatal follow-up, your obstetrics follow-up, your midwife, and so on, your obstetrician. So that is usually the first point of contact for such an issue then.
Yes, that's usually the first point of contact. I'm not sure if I can speak for how well the screening can be done there, but that's usually
Sure.
the first point of contact. And I think that the chances that you will get an intervention is higher if you mention it at the review, because there are scheduled reviews when a person has a baby. And so it's easier for the person to mention it when they have the scheduled reviews than to get up and just go into a clinic and say, look, I feel this way. And then also there's a lot of guilt around that. You can imagine when a mother has a child and they're not as excited. They feel so guilty. Like, how do I tell people I'm not excited? I'm feeling like getting rid of my baby. And so they try to suppress it for a long time. And so we're even going for help to go and talk to somebody and explain that this is how I feel is quite difficult. And so the more people understand that this can actually happen, the better.
Okay, that's good. So I know in some countries, actually, you're mentioning the screening aspect, that some countries are stronger on screening during postnatal visits about depression than others. I know probably our country is one of the weaker ones, but I know in some countries they make it a point to actually screen for postnatal depression during those visits. So that's a good point to catch. So a woman has come and she's gotten, the diagnosis then through this intervention. What next for her? What are the options in terms of getting treatment? What are the things she can do to help herself?
Okay, so one of the first things that we try to do is restore the sleep, because when there's sleep disturbance, it's one of the things that really, really affects the mood. So depending on how severe it is, if a person just has what we call maternal blues, we work at doing interventions that are non-pharmacological. So bring in the support that they have, whether it's their mother, their aunt, or their nanny, encourage them to have as much sleep as they can get and not feel guilty about it. So that's an important aspect. And also help them to understand there are some roles that they can delegate. Of course, things like breastfeeding, you can't, but you can delegate things like cleaning bottles. And for new moms, those are big things, because they want to show that, they've got it all together. They can do that. They can wash. They can. So if they are failing to do that, it's almost some kind of judgment on their part that they're not being the perfect mom. They're not being. So just being able to tell them that it's okay for you to let go of that. It's okay for you to take a nap. It's okay for you to have someone else watch over the baby while you sleep. And then also maintaining adequate hydration and nutrition. Those are the two things that we emphasize. The third thing we encourage the person to do is to have some form of exercise, not vigorous exercise, even just a 30-minute walk a day, because that quickly helps the body get into shape. It increases the blood flow to the brain, which needs the balance of the neurotransmitters quickly so that the person's mood can get back. And then also the other thing that we try to help them to do is to get a routine. A routine helps. One of the things that disrupts mood is also unpredictability, where you are awake at 2 the next day and the other day you're awake at 6 and so on. So try and help them to get a routine quickly. So those are some of the non-pharmacological interventions, and also get psychosocial support in terms of someone to talk to. So it may just be on the phone, or it may be a neighbor nearby, but getting somebody to be able to talk to, and being wary also of the idea that, some people may judge you. So finding someone who can be a safe space, that you can talk to about what you're going through and some of the challenges that you're experiencing. Then
Okay.
in terms of the pharmacological interventions, depending on how the symptoms are manifesting, one of the first things we do is give a sedative. And we try to use a sedative that will not have any effect on the baby because we want the mother to continue breastfeeding. So we give a
Okay.
sedative. And if a person is having, there's two types of mood symptoms. There's the depressive symptoms, and then there's the manic symptoms where the person is really hyper and so on. If the person is really hyper, we give an antipsychotic as well so that the person can calm down. If the person is in a state where they can actually harm themselves or harm the baby, then we recommend that we have to admit the person and
Okay.
and treat them so that they're away from that environment where they can't rest and they're with the baby and they can harm themselves. In developed countries, one of the things you actually have mother-baby units. So women are admitted in places where they can still have some kind of access to the baby so that the transition is easier when they get discharged. But in extreme cases, like I said, we have no choice but to admit the person so that we can give them better care. And also during this process, an essential component is counseling the family, helping them to understand what's going on, helping them to understand the support they need to give to the client. Yes.
Okay, that's quite interesting. So two things I want to touch on. The first is the aspect of harming themselves or the baby. So I guess I about postpartum depression as such. This then is the other diagnosis of postpartum psychosis, is it not? I just want to distinguish the two so that it's clear to the people that might be listening.
No, actually, even in postpartum depression, because as you know, even in severe cases of depression, people are suicidal.
Oh, I see.
So,
Okay.
yes, so even in postpartum depression, you have people with typical symptoms of depression, and they think, sometimes it's because of the guilt that they experience. Like, I'm a mother and I don't want to take care of my baby, or I'm a mother and I feel overwhelmed. What kind of a person am I? I'm better off not being on this earth. If I can get away, then I won't have to neglect my child. I won't have to look
Okay.
like I failed as a mother. So they may actually think about killing themselves. And the issue about killing the baby comes in with the issue that, look, before the baby, I was fine. So all these problems have come because of this baby. If I get rid of the
I
baby,
see.
then I will be okay. So in severe depression, there's impaired judgment, really. And so
Okay,
some of
so
those, yes.
an extension of the self-harm or suicidal ideology thinking in depression generally that now extends to the scenario of the baby and the mother. I think I understand that more clearly now. So I think what this points out is that the danger is quite real in terms
Yes.
of that. So you have talked about this psychotic drugs that may be necessary on the also sheds a bit of light on antidepressants during this period.
So antidepressants can also be given, but we typically don't give antidepressants because, well, studies have shown that in this phenomena, trying to help the person just get to a point where they can have adequate sleep and sound judgment usually is enough to get them well. But if the depression continues, even after like 3, 4 weeks, well, about 3 weeks, then you would give an antidepressant. Some people actually who would end up with full blown depression, for lack of a better term, after a postnatal phenomenon, and that would be the start of their clinical depression. So even after the postpartum period is finished, you find that this person now has depression, and we now have to treat them for depression. And so that diagnosis comes in, and they're now confirmed depressive, so to speak. Yes. So those are some of the factors that would determine whether the person would then go onto an antidepressant immediately or not. But a number of studies have shown that giving an antipsychotic and a sedative, such as benzodiazepine, would help in the immediate and almost always resolve the symptoms without necessarily adding an antidepressant.
Okay, all right, that's quite interesting. So makes it more important to get help. It's good to know that non-pharmacological or non-medication interventions work very well and can actually go a long way in resolving this without having to get to the stage of needing medication. If somebody seeks care early, I guess that's the point here, is you have to seek care early and be aware of your and how you're feeling early. So these interventions are very important, but one aspect is, can you tell us more a little bit about partner support? Because I remember, with my kids, getting up some nights to put them back to sleep when they're crying, or feed them, and allowing my partner to sleep and so on. So I guess there's a lot that partners can do as well. Could you shed a bit of light on that?
So I'm glad you said that. One of the things we talked about earlier was about some of the risk factors in somebody developing postpartum depression. And one of them was actually having marital problems or partner difficulties in the relationship. So first of all, having those difficulties already is a risk factor. And so partner support in that regard is very important. But secondly, remember what we talked about in terms of the interventions that are needed, like helping the person to sleep more and giving them a bit more rest, having some predictability in the routine. It's actually a lot easier for the partner to do that, especially if they're living together, than it is for anyone else who comes in to help, because that's a more sustainable routine, because the people actually live together, as opposed to a mother or a maid or a nanny or an aunt that just comes in to help. It's actually more sustainable if the partner is present and helping the person adjust in the routine. It's a very steady source of stability, and stability is essential for recovery during the postpartum depression. Very, very important. So in terms of what the partner can do, so some of the stuff you already said, so being able to do some feeds. So one of the things that I think is helpful, I think as women, there are certain things that women think are very important, like whether I breastfeed myself or whether I use formula. And so women would be resistant to doing that. But sometimes what the person can then do is express, so that the partner can feed the baby later in the night to help feed the baby. Or if expressing is not an option, they can then use formula, because the life of the mother and the baby are of prime importance. So then in such a case, it's important to do those kinds of adjustments. Also, just the partner being there to listen as the person talks and complains or whatever about how they're feeling, and trying to be a judgmental listener, offering unconditional love and support during that period, pampering them. The back rubs and the feet rubs are very important, and they work. So all those really help to improve mental health as well. They could also help the partner by supporting them as they take their walk. So they walk together. It's more encouraging to do that. Helping them prepare some meals, get some healthy food that would help them in the recovery process. So all those are essential elements that can help to boost up the mental health.
I think that's quite interesting, especially in cultures where when the baby comes, it's the mother-in-law who helps with the children, and so on. There's a huge role that the partner can play, and I think that's very important, even to recognize the symptoms and recognize that maybe my partner needs help. Let me help her get the help she needs. I think that's something as men we can be more aware of and try to help with. So thanks for that. That's quite interesting. So as we wind up, Maria, any last words or anything else you'd like to add on this topic?
I guess one of the things I just wanted to add on is the issue of sex. And I think that has its own place, because for a long time the woman will not be interested in that, and sometimes they feel pressured that they should get into that aspect, and that can become a source of conflict or poor support from the partner. But just making sure that that is something that they communicate about, because not communicating will add extra stress and tension in the relationship. So that's something very important to communicate. And that can be due to the maternal blues, it can be due to the hormones, it can be due to delayed recovery because of maybe stitches and so on. Whichever the case, communication is very, very important during that period of time. The other thing I wanted to say is that the good news is that postpartum phenomenon, as I said, is treatable, and the outcome is usually quite good. So it's something that people should not feel beaten about when they experience it. It should be positive. There's help out there. You can recover, and life can go on pretty well.
Okay, that's a good last word, and very encouraging for anybody out there who may be going through postpartum depression. You know, when we posted our other videos, other interviews about depression generally, got in the comments some people asking about postpartum depression and saying, oh, my sister might be going through this, or I'm going through postpartum depression. Can I have more information? So I'm sure this interview today will help a lot of people to be more knowledgeable about it and see what help they can get for themselves or their partners or their loved ones out there. I really appreciate your time. Thank you very much. I'm sure I will call out on you again for another interesting topic around depression. So I will pick your brain a little more on this issue.
You're welcome. Thank you for having me.